Hi, I'm Sonu Jain. I'd like to welcome you to our AHS Advanced Practice Provider webinar series. Uh, we have a series of 3 webinars that we are doing through the association, and one was on June 17th. Just to remind everyone, this allows you free access to the Access Webinar series is free, but allows you 1 year of complimentary affiliate membership. There's a robust menu of membership benefits being part of the AHS, including discounted annual meeting registration rate, and your partner guest or child registration is also free. Just to remind everyone, you need to participate in 2 of the 3 webinar series to get access for this, and this is supported by Endo Pharmaceuticals. Next slide, please. So today's webinar is going to be on in-office procedures that you as an APP can perform and how to code appropriately. So we have an outstanding faculty of Dr. Courtney Carlson Strother from Mayo Clinic, Dr. Mark Recant from the Philadelphia Hand to Shoulder Center, and Sarah Taub, PAC from Emory. And I'll be your moderator today. And again, I'd like to thank Endo Pharmaceuticals for sponsoring this. Next slide, please. Future webinar that will be upcoming will be next month. Please register for that. You can click on this QR code. Next slide, please. And as I mentioned earlier, we had a previous webinar that you can watch on our website. Here again, you can view this recording by scanning that QR code as well. This webinar will be recorded as well. Next slide. And a final reminder, we do have our upcoming annual meeting in Chula Vista, California in January. So please join us for that. It's going to be a wonderful meeting at this wonderful brand new hotel. Next slide, please. Thank you. Well, I'd like to go ahead and introduce our first speaker, and that's going to be Dr. Courtney Carlson Strother from Mayo Clinic on tips for performing in-office procedures. Take it away, Courtney.
Thank you so much. I'll pull up my slides here. Wonderful. Thank you to AHS for AAHS for inviting me to give this talk this evening, and welcome everyone. So like was mentioned, I'm going to start our evening off with talking about in-office procedures and tips and pearls for how to perform them. So the objectives of this talk, we're going to go through just in general considerations for using steroids on patients. Then we're going to go through some of these various in-office procedure techniques, as well as talking about some digital block techniques and different surgeries or procedures that we can perform after doing a good digital block. So in general, when considering using steroids, it's important to know that there's a difference between fat-soluble and water-soluble steroids. Fat-soluble steroids are absorbed typically more slowly because the effect takes into effect once the enzymes within the cells break the fat-soluble steroids down. And because of this, it might be slower onset of the steroids, but in general, it's thought that these fat-soluble steroids have a longer lasting effect. Typically, fat-soluble steroids are used with joint injections, particularly in the consideration of joint arthritis pain. But one important disadvantage of using fat-soluble steroids is they do have a slightly higher increased risk of side effects such as fat atrophy or skin atrophy. And examples of fat-soluble steroids are triamcinolone, such as Kenalog, or methylprednisolone acetate, or Depo-Medrol. Water-soluble steroids, on the other hand, are rapidly absorbed within cells and do not require the cells to break them down. And because of that, they typically have a quicker onset, but potentially a slower or less long duration of the effects for the patients. Typically, water-soluble steroids are used for soft tissue injections, such as trigger digit injections. An example of these would be dexamethasone sodium phosphate or betamethasone sodium, or also called Celestone. One consideration that you should always counsel patients prior to giving anyone a steroid injection to their upper extremity is to counsel them on some potential side effects from steroid injections. Particularly, they may have a temporary increased risk in pain and swelling following steroid injections. Again, patients can have this risk of getting fat or skin atrophy, particularly if you're injecting in a subcutaneous area. And they also could get skin pigmentation changes, again, particularly if you're doing a subcutaneous area of an injection. Then, of course, if you have a patient with diabetes, it's really important to counsel them that they may have a temporary increase in their glucose levels for up to 48 hours after the steroid injection. Some ways that you can consider minimizing pain with any sort of injection you're going to be doing on the patient is as follows. So one thing you can do is immobilize the syringe with 2 hands after you puncture the skin to minimize the amount that the needle moves within the skin and minimize the pain. You always want to try to use the smallest and shortest needle during your injections. And your initial injection and point of contact to the skin, you want to try to get the needle as perpendicular to the skin as possible to minimize that contact area of the sharp pointy end of the needle. And then it's really important and can be very helpful for patients to use sensory noise to minimize the pain. Things that are sensory noise would be pinching the nearby skin, such as in this upper right picture here, as you go to inject the area that you're going to be inserting the needle into, or using things like cooling sprays such as ethyl chloride, or vibrating tools such as in the pediatric world using this Buzzy Mini. And even just simply asking the patient to take a deep breath as you start their injection can contribute to some of this sensory noise to minimize the pain. If you're giving an injection, particularly in the setting of a digital block or just administering straight local, don't advance the needle very slowly, and always make sure the needle is behind the wheel of the local and that you are injecting. And if you have to reinsert the needle, only reinsert it into an area that you have tumescence and you can tell that the skin is already numb. So to go through some specific in-office procedural pearls, one of the most common things that we see in hand surgery practice is carpal tunnel syndrome. Just briefly as a reminder, carpal tunnel syndrome is pain, numbness, and tingling in the median nerve distribution that oftentimes will waken people up at night and can have daytime exacerbations in the moderate to mild syndrome type of pain. In severe symptoms, patients can start to have weakness, and in general, the treatment for mild to moderate carpal tunnel syndrome is starting with nighttime bracing, but you can also consider doing steroid injections for these patients. Carpal tunnel injections can have a couple different benefits. The first benefit is also it can be a diagnostic tool in addition to a therapeutic tool. So for me, I will use carpal tunnel injections as a diagnostic tool if a patient's symptoms are not classic for carpal tunnel, or if you're not sure if all of the symptoms that they're having or experiencing is directly related to their carpal tunnel syndrome. So after I do the injection, I ask the patients to pay attention to how their symptoms change or do not change over the coming weeks. If they have complete resolution of their symptoms, even for a couple of weeks, that can be really diagnostic and prognostic that they'll likely have complete resolution of these symptoms if they go on to have a carpal tunnel release. If they have no relief after their injection at all, you can counsel them that they may have improvement in some symptoms after surgery, but you can also consider if they need to get additional workup or referral for other potential causes of their pain. For therapeutic consideration of carpal tunnel injections, I counsel all patients that about 3/4 of patients will have good pain relief from the carpal tunnel injection at about the 6-week mark. However, only about 20% of those symptoms or patients will remain pain-free at 1 year. So if it's a classic diagnosis of carpal tunnel, I use the carpal tunnel injections for therapeutic, more if the patient does not want surgery or has something going on in their life that they just want to prolong surgery, or they're just not interested in surgery at that time, but want to get relief of their symptoms. Some techniques of doing the carpal tunnel injection: I use a 25 gauge needle that's usually about 1 to 1.5 inches long. I typically will use a 5 cc syringe, and I will use a 1% lidocaine and Kenalog or triamcinolone, the 10 milligrams per cc dosing. And in total, I use about 4 to 5 cc's of the lidocaine and steroid. The starting point for this injection is going to be just ulnar to the palmaris longus at the distal wrist crease. And a way that you can determine if a patient has a palmaris longus and mark it out is ask the patient to put their pinky and thumb against each other, pinch, and then bend their wrist down, and that will oftentimes get the palmaris longus to stand out, and then you want to be just ulnar to that. If they don't have a palmaris longus, and injecting inline the radial border with the ring fingers, typically a safe landmark. Typically for these injections, I just go subcutaneous, just in case the median nerve is not at the exact location that you would anticipate it to be by standard palpable landmarks. And if you happen to go subcutaneous and the patient has sudden onset of worsening pain into their thumb, index, and long finger that may indicate that you could have hit the nerve, I will typically take the needle out and try to march a little bit more ulnarly. Or if the patient doesn't want to tolerate that injection just by landmark guidance, you certainly could get out an ultrasound or refer to a colleague who does these procedures under ultrasound guidance just to be sure you don't hit the nerve. For trigger fingers or thumb, this is thickening of the A1 pulley and peritendinous changes that will result in catching, clicking, or locking of the finger anytime the patient flexes their finger down. It's typically worse in the morning. And the mainstay of treatment for trigger fingers is oftentimes giving a steroid injection, with studies showing that people will get 60 to 92% of patients will get long-term pain relief of their symptoms from a single injection. If you have to have recurring injections, that does have declining successes, or if they have diabetes, it's less likely to cure it, but it can still be beneficial. For these injections, again, I use the same needle, but I usually use a 3cc syringe to give me better control. I oftentimes will use 1% lidocaine and celestone in this consideration, given it's a more soft tissue injection, but many of my colleagues will use Kenalog as well, which is okay. The starting point for trigger finger injections is usually directly midline at the level of the A1 pulley, and I've sort of roughly marked out the main spots that I will do my injections for the various fingers. For the thumb, that can be a little tricky to find the midline. I will sometimes look directly at their nail to find where that midline is and then march all the way down volarly to make sure I'm centered and not off to one side. And sometimes you have to turn the patient's thumb to really be staring right at it than just off to the side. Now, there's some studies that looked at the difference between intracious injections versus just subcutaneous injections for trigger digits. And studies like this have shown that there's really no difference in the efficacy of injections based on if you're subcutaneous or intrasheath injections. There's some people that suggest that subcutaneous injections may be less painful for the patients. So what I typically do is go through the skin, start injecting to give patients some immediate pain relief. But then I usually will advance my needle to try to feel myself go through that sheath. And if you put your contralateral hand proximally and distally along the sheath, you'll sometimes feel the steroid and the lidocaine go through the sheath, which can be really satisfying and rewarding to know you're in the right spot. The next thing I want to talk about is Deuquarvein's tenosynovitis. So this is, again, similar to trigger fingers, where stenosing tenosynovitis of the first dorsal extensor compartment. Patients usually will report pain at the base of the thumb or the radial side of the wrist. It's very common in pregnant or lactating women, but it's also common in middle-aged patients as well. The mainstay of treatment for Deuquarvein's tenosynovitis is giving a thumb spica brace or cast. You can use anti-inflammatory medications, but also steroid injections have shown to give good pain relief in these patients. For these injections, I'm going to use the same similar needle. I use around a 3 to 5 cc syringe for this. And then this one, I think it is important to make sure you're using celestone or a water-soluble steroid for these. Again, because this injection is fairly subcutaneous, and there's a reported 5 to 10% risk of getting complications such as fat atrophy, skin atrophy, or hypopigmentation with these injections. Your starting point is going to be directly over the tendon sheath, and sometimes it's easy or helpful to place a rolled towel underneath the wrist to slightly ulnar deviate the wrist and help you find that tendon sheath. I usually try to roll my finger back and forth over it at the level of the radiostyloid to make sure I'm in the right spot. And for this one, I make sure and try very hard to get intrasheath before injecting, again, to try to minimize any of those risks of hypopigmentation, fat atrophy, or skin atrophy from this injection. And oftentimes, again, you can feel yourself poke through the sheath and will feel the steroid run proximally and distally along that sheath if you're in the right spot. For thumb-based arthritis pain, this is sort of similar, but it's very classic usually with thumb-based pain, and also patients will note thenar pain and soreness. It's usually worse with any sort of activity such as pinching, gripping, turning doorknobs. The mainstay of treatment for thumb-based arthritis, again, similar NSAIDs bracing, but we know CMC joint injections can provide patients quite a bit of pain relief before considering surgery. These injections can be a little bit more challenging under anatomic guidance, but it certainly is doable and something that I do in clinic very often. Again, I'll use the similar size needle, and I will use a 3 cc syringe for this one, because really getting more than 2 cc's of any sort of steroid and lidocaine combination within this joint, I oftentimes find is very difficult. And I warn patients that this injection, while it does provide good pain relief, can be uncomfortable because even putting 2 cc's into a small joint space such as this can be uncomfortable for the patient. The starting point for CMC joint injections, typically before even getting the needle close to the patient, I'm using my contralateral hand to pull gentle traction on the thumb and then feeling with my index and thumb finger at the base of that CMC joint, sometimes even putting my nail to confirm that I am in a soft spot that I feel is going to get me reliably into that joint. Sometimes, such as the bottom left picture here, I'll use the cap of the needle to even mark my spot before uncapping the needle to do the injection. And if you go into start your injection and you hit bone, I will just inject a slight amount of my local with steroid to give patients some pain relief as I march around with the needle until I finally fall into that joint space, which is you'll feel that clear difference before I inject the rest of the medication. These injections can also be done very reliably under ultrasound guidance and sometimes under fluoroscopic guidance as well if you have access to a fluoroscopy machine in clinic. And then the last thing I want to talk about was doing digital blocks. Indications for digital blocks, there's a whole bunch of things that you can do in office for patients if you're able to do a good digital block. You can do laceration repairs, nail bed repairs, even revision amputations. If someone has buried hardware or foreign body, you can get those out. If they present to clinic with infections such as a paronychia or felon, you can get those decompressed. Or if they present even with a DIP or PIP dislocation, with a good digital block, you can oftentimes get these reduced under fluoroscopic guidance. There's sometimes feels like 100 different ways that have been described of giving a digital block. So there's very different techniques. I think what's most important is that you know the anatomy and you can get both the dorsal sensory nerves as well as the volar main proper nerves to the affected finger with a good block. So some people will do 2 pokes dorsally, such as this right-handed picture, where you start dorsally, get the sensory nerve, and then you advance your needle volarly to try to get the proper either ulnar or radial digital vascular bundle on either side, and vice versa, do a second injection onto the opposite side. Some people will do 2 pokes volarly to first go after the digital neurovascular bundle and then do a wheel onto subcutaneously dorsally as well. And then it's also been described on doing an intrasheath injection for a digital nerve block. And this is a reliable way that you can do it. Just make sure if for whatever reason you're using lidocaine with epinephrine, I would not recommend using this intrasheath injection if you have epinephrine within your local, as this could result in some necrosis of the tip of the finger. So the way that I typically like to do it to try to minimize my pokes is I do 1 volar poke in the center of the affected digit that I want to get numb, and then I guide my needle both ulnarly and then radially to get the volar nerves, and then I make a separate wheel dorsally to get the dorsal sensory nerves. It is very important if you're going to do some sort of procedure such as a nail bed procedure or any procedure on the dorsal aspect of the finger or very fingertip to do this dorsal wheel. Otherwise, you'll find that patients will have complete anesthesia from your block if you only go volarly. So just in the last few minutes we have, I wanted to touch base on some of the infection procedures you can do after you get a good digital block. So paronychias are soft tissue infection around the nail fold. And if it's untreated, it may develop into an abscess. So if you have these present in clinic, you can, after a good digital block, get a 15 blade and run it along the affected side of the nail, elevating the part of the eponychium or the paronychium that's involved. Sometimes in more severe cases, you might have to take a sliver of the nail out to get everything well decompressed, and then start patients on antibiotics and start wound care. Typically, I like to use Hibiclen soaks for the patients to get all that abscess and infection out. And then similarly, but slightly different, treatment of a felon. This is a soft tissue infection that can develop in the pulp. Again, it will form an abscess if left untreated. And it's also almost been described as like a compartment syndrome within the pulp. So if severe and left untreated, it can actually affect the blood supply to the distal phalanx as well as the skin eventually if it gets bad enough. And the treatment sort of similar to a paronychia, is after a good digital block, doing a longitudinal incision over the area of the maximal fluctuance in pain. So either doing a longitudinal incision on the ulnar or radial side, or directly in the middle at the whatever the area of your maximal tenderness is. And then you can use a hemostat to do blunt spreading. You want to get across the septae that will be there and present in the pulp to make sure you decompress any areas of abscesses. And then similarly, you'll start wound care and do some PO antibiotics for your patients. So in summary, many common hand pathologies can be diagnosed and treated in clinic with point of care injections. Ultrasound and fluoroscopy can be used as adjuvant treatment for these procedures, but as long as you have good knowledge of the anatomy of the hand, a lot of these procedures can be done by landmark guidance as well. And then knowing proper injection technique, you can really minimize the patient discomfort for these injections while maximizing the therapeutic benefit. Thank you.
Thank you, Courtney. That was awesome. I mean, a real like tour de force of like a bunch of hand procedures, and I mean, this is great. So thank you for that. That was wonderful. Now our next speaker is Mark Recant. He's going to talk about coding for in-office procedures. Mark.
Thank you. I hope everyone can hear and see me. That was a great segue. Changing gears to a little more of what can be done in the office, some coding tips. And I think it starts off kind of with what we really have to think about, right, as far as creating an accurate medical record that's compliant, also providing good care, minimizing liability, and overall developing good habits. This theme will keep coming up. You can't bill for just what was done. You can only bill for what was done and is documented. So we'll briefly talk about some documentation concepts. I think the CPT codes are confusing, but you can see they all have 5 digits. Those beginning with 2, 3, and 6 are typically surgical or procedural. 7 are the radiology codes. 9 is sort of your office visits. Any of these codes can be used by any physician or APP. They're not restricted to any specific specialty, and they're designed by the AMA and other advisory committees, which would be another talk. So we have to match up the correct CPT for the correct ICD-10. And then, of course, we have to make sure the service is covered by the patient. And like a slot machine, you need these 3 cherries all to be in a row to get paid. Unlike the casino, it's not a matter of luck. This is all within our control. So documentation, accurately recording the work. Obviously, we've talked about this. If the documentation evidence doesn't support the coding, we're going to have problems. Other thoughts, just while you're doing your documentation, avoid symbols, such as you can see here with lipids or blood pressure. Other documentation strategy, avoid history of or SP for active disease, because that sort of implies a past condition. Avoid linking terms, and for each diagnosis, indicate a treatment plan and assessment to stable worsening, which will help with upcoding, as we'll see down the road. Coding's really converting the work that we do with each patient into a numeric code, so someone can figure that out. We'll talk a little bit about these RVU tables, but they're there for every procedure under the sun, for every for every CPT, there is this list. It's a lot of information. So once this talk's over, you can get all this information from cms.gov. You go to your Medicare fee schedule lookup, which I'll show you. Other professional organizations like the Hand Association, AMA, and AOS have other tips, or you can just go to a coding workshop. So, all right, there's more. There's global periods, which we'll talk about, variables such as multiple procedures, bilateral, and one of the things we'll touch on a lot is assistant surgery fees, as that really is applicable to the APP world. So thinking about this, multiple procedures, particularly for Medicare or CMS, we get paid 100% for the first procedure, 50% for the next, 25% for the one after, and 25% for the fourth. The 5th procedure that you do at that surgical setting is basically gratis. So we also have to understand global periods. We'll talk some of these. Your minor surgeries, we'll talk about a little bit, have 10-day global. More major surgeries have a 90-day global, which means you're not really billing for anything in the postoperative care, except if something's unrelated. Well, how do you know what the global period is? Again, that RVU table that I'll touch on has that listed, as you can see here in the red box. So again, one of the thoughts is APP payments. So APP services provided outside a hospital, such as your office, are paid at 85% of the amount a physician gets under the current payer schedule. Only if no other facility or other provider charges were at stake here. And we'll talk a little bit about that. That kind of gets into co-surgeons. We each receive 62.5% of the allowable amount. Here where it gets tricky. The APP receives 85% of the 16% of the allowable amount. The primary surgeon still gets 100. So one of the things to think about is as you are assisting, triple check what codes you're assisting on, because you'll often be amenable to getting that 85% of the 16%, and that goes right into your coffers. And again, how do you know if this assistant is allowed? You go back to that beautiful RVU table that exists, and you can see here highlighted in the red, assistant surgeon, yes or no, co-surgeon, yes or no, and each CPT code has this available for us online. So some things, what can we do in the office? Well, here's a great example, trigger finger releases. The code is 26055. If you do it with some local anesthesia, there's a CPT code for local, 64450. And an office procedure, we're reimbursed $5.99 and change. Local anesthesia gives us $75 and change. If that same exact procedure is done in the operating room, you can see the difference there is a $351 versus almost $700 if you do that trigger finger right in the office, and patients can be one and done. Well, we heard a lot about injections, which was wonderful. The CPT code for that is 20550. And again, that's really what we're getting in the office, $59. If it's done concurrent with another procedure, at best, you're going to get $40. And that same 20550 goes for tennis elbow injections, de Quervain's injections, CMC injections that we heard about earlier. Well, we heard a little bit about fingertip injuries. These are pretty classic and very common. The dreaded crushed finger, but it can be a very nice thing. If there's an open fracture, we'll code for that repair. We'll code to irrigate that open fracture, which I think is standard of care. And yes, there is an assistant surgeon fee available for that code. Nail bed repair, of course, 11760 has a 10-day global and is available to the assistant to surgical bill. If there's a laceration further down the finger, you have 13131, which is a 10-day global, and again allows for the assistant. Well, what does that really mean to us? If you break it down and we do that IND of the open fracture in the office, you can see reimbursement is $658. If you go to the operating room, you lose more than $200. Similar for your nail bed repair and your laceration repair. You can see the grand total if you're doing a fingertip repair in the office is a net benefit or betterment of $457 and change. Something that we can all do in the office setting. Quite nice. Other traumas, penetrating wound, you're going to check that forearm wound or hand wound and you see a tendon. Well, you can get reimbursed for that expiration. You can see the code is 20103. It's a 10-day global, and it's much more valuable to do that in the office, as you can see, with more than $200 reimbursement to do that in the office rather than the OR. Forearm laceration repair, again, a nice thing to bill for and to do. You can see the difference in the office is over $100 for us to knock that out, not including reimbursement for the local anesthesia, which I did not include on this slide, but certainly does exist. A little bit touching on collagenase injection. The injection has a code you can see here, 20527, reimburses us $90. The next day or two, you will do the manipulation, 26341. If that's done in the office, which it commonly is, reimbursement is $121. And again, these are CMS Medicare figures for the Philadelphia market. They are slightly different from market to market, but not that different. There's a drug cost where we use J codes similar to the J code we use for cortisone injections, which is 0775. And typically Medicare allows the office to get reimbursed 6% of what the total medication cost would be. So that is another added benefit to you and to the practice. We heard about the finger abscess. That was fantastic. We're doing that in the office, just as we heard. You can get reimbursed $477.80 if you do it in the office. If you decide to go to the operating room, that drops down to under $200. That has a 10-day global, and it has an assistant fee capability. Hardware removal, very common. Someone's had a pinning, a finger pinning, or any other pinning. If it's removed in the office, 20670, you can see there's almost a $200 or more than $200 difference. Why not do it in the office? A 10-day global with an assistant fee, a fantastic concept. The dreaded mucoid cyst, for those that have seen them, we all know them. We know what they look like. If the patient opts to have that removed and it's performed in an office setting by someone like yourself, reimburses $573 in Philadelphia. In the operating room, that reimbursement drops down to $309. Begrudgingly, that does have a 90-day window, and the assistant fee is available for us. Quite nice. Other things that have assistant surgeon fees, although it cannot be done in the office, are these that we commonly see: carpal tunnel, de Quervain's, thumb, CMC, suture suspension plasty, trigger releases. Interestingly, an ulnar nerve release at the elbow does not have an assistant surgeon fee permissible. Interesting. I don't know why. Other things that also have assistant fees and can be considered are extensor tendon repairs, such as treating a mallet finger closed or open. It's the same code. You can see 26432, extensor tendon repair on top of the hand. Again, something that can be done in the office with appropriate coding. I kind of covered some of these things. This is really the key slide here, and I use this pretty regularly because it has all the CPT codes. It has the RVUs for those that are RVU based. It also gives you the assistant fee capabilities and the global as you scroll across from left to right. And you can look up 4 or 5 codes at a single setting and then simply refresh it as you go throughout your day. So real quick with modifiers, 22 is a procedure that requires significantly more work. 25 is important, and we'll see why this is important. It's a separate service provided on the same day. 57 includes a decision for surgery on the day of surgery. So it's sort of like your emergency upcode for those emergent cases. So here's the key, though. Insurers will generally not pay for an office visit and a procedure on the same day unless you apply that modifier. So if you see a patient for a trigger finger, you put your evaluation hat on, and then you decide to do that cortisone injection we just heard about, you have to use that modifier. And I find it helpful to use a different ICD-10, such as finger stiffness or finger pain, to correlate with the evaluation. So that if you just bring the patient into your office for that trigger finger surgery, you obviously can't bill for an office visit at that same surgical setting. So some thoughts: poor documentation is why we didn't get paid. We're not justifying why the procedure is done. The codes don't match. The claim wasn't filed timely. We're going to kind of skip through this one in the interest of time. This is something I wanted to kind of touch on with the last few minutes. And this is really the change in CMS or Medicare's decision-making guide. They've gotten away with a lot of the bullets that we saw years ago with review of systems and trying to capture 15 different bullet points. And this is a good way, and not terribly difficult, to go from a level 3, which is the complex, low complexity, to a moderate complexity, which is a level 4. And I've highlighted that. The next slide is 4 to 5. So this one, you just see basically the difference is under moderate. you have to have one of these two components. So documenting a review of previous notes, super easy. The patient has a chronic illness or a new complaint, again, which is classic if someone's coming in for any one of the things we've talked about this evening. And then a moderate decision-making function. So prescription drug management is one. Discussing surgery is certainly another. And it's quite easy to get to that level 4 if you're doing those things and you're reviewing past medical records, reviewing a test such as an MRI or an electrodiagnostic study is really going to get you to that level 4, which does increase your reimbursement 25%. I apologize. This was going from 04 to 05, so getting to that higher risk is much more difficult. So to get to a level 5, you really have to think about 2 of these criteria. Sometimes if a patient has a comorbidity like diabetes or other conditions that are chronic, you can get to that level 5 by documenting you had a discussion regarding the higher risk of their surgery. So it is something that can be done. So again, we kind of looked at some of these references, and I'll leave it at that. So thank you for your attention.
Awesome. Great talk, Mark. I think you really covered it in such great depth. And I mean, I think it's one of the best coding talks I've heard on this. So thank you so much. I do love your RVU table. So our next speaker is going to be Sarah Taub, who's going to give the APP perspective on in-office procedures and pearls. So you can go ahead and take the floor, Sarah.
Awesome. Yes, I'm Sarah Taub, coming from Emory Healthcare in Atlanta, Georgia. Thank you so much for having me. It's an honor to be here, and thanks to AAHS for providing content for APPs specifically. I'm going to be talking about in-office procedures as well for the APP from the APP perspective. I have no disclosures about this topic. So our goal today is to talk about in-office procedures that are going to increase your value and productivity as an APP and also your patient satisfaction. And I am really going to be focusing on ultrasound and incorporating this into your practice. I have this very fancy graph here looking at 2023 to 24. This is actually my work RVUs. So 23, I was really getting started with ultrasound. And then in 24, I would say it was really incorporated fully into my practice. So it almost gave me an extra 1,000 RVUs. I also got more admin time in 24, so less time in clinic and still significantly more RVUs with incorporating ultrasound. So as an APP, you're already licensed to use MSK ultrasound. There's definitely courses you can take to kind of help improve your skills, but there's no extra training that is needed. Ultrasound is great for confirming the location of your injection. There's actually a great study out of NYU that looked at glenohumeral joint injections, either blind or with ultrasound done by surgeons. It was significantly more accurate when using ultrasound. These injections tend to be quicker because you would know exactly where you're placing the needle, so you don't really need to feel around with the needle or hit the bone, which does make it less painful. And then Mayo did another great study kind of looking at carpal tunnel injections, blind versus ultrasound. And they did find that it was actually more effective, like long-term, using ultrasound for those carpal tunnel injections. So it makes it quicker, more effective, and patients just really love it. They kind of get to look at their own body kind of from the inside, and it's a huge tool for them that they really love. And then of course, like I said, it increases your RVUs. So we'll jump right in. The first one is your CMC injection. As you all know, you can feel landmarks to do a CMC injection, but the ultrasound again makes it a lot easier to be more precise with your needle placement. So top left up here is kind of my setup. You want the patient between you and the scanner. You want everything you need available. Down here, of course, is where my probe is, which will be the blue, and the green is needle, so where I'm placing the needle. And then just a video of you can kind of see the needle go in, the soft tissue move, and the fluid filled up. I find this really helpful too if patients have like crazy bone spurs or slightly abnormal anatomy. This helps make the injection smoother. Next is carpal tunnel, and this one's kind of twofold. So we're going to talk about carpal tunnel injection, but also talk about diagnosing carpal tunnel. So an in-office diagnostic procedure. So Dr. John Fowler's done a lot of great work on this, and we've found that if your nerve is measuring cross-sectional area greater than 10, that's compatible with carpal tunnel. So patients with a pretty standard presentation and a positive CTI-6, you can use ultrasound to very sensitively diagnose carpal tunnel in the office. And this saves the patient time, it saves them some money, it saves them lots of pain because they hate those EMGs. So on the left here is actually just me scanning a carpal tunnel. Your nerve should look like this, like the end of a broomstick, which looks different from the tendons, which are hyperechoic. The other thing you can do is kind of scan distal proximal. And as you move towards the body, as we know, tendons are going to turn into muscles, so they're going to flatten out. We'll play it one more time, where the nerve will stay the same, about the same size and look the same. So that's an easy way to kind of figure out, am I looking at the nerve? Am I looking at tendon? Over here is measuring a median nerve. This one's measuring 6, which is normal. Next, we have one measuring 15. So this one's carpal tunnel positive. And then here is just a quick shot of the injection. So you'll see the soft tissue move and the fluid kind of fill up right in here. This is the placement here. Very simple. You just have the patient hand on the table, probe right over it. And of course, now we're making sure we miss any important structures because we are staring at all of them while we do this. Then cubital tunnel, this one is technically a little bit more challenging just because your elbow is so pokey and bony. So I have them laid down on the table like this, arm like shoulder externally rotated. I rest their hand on the ultrasound so there's less moving parts. And I just place the ultrasound kind of right over the cubital tunnel. You should see the medial epicondyle like this, olecranon here, and then your nerve. And again, it's not as pretty as a picture as the carpal tunnel, but nerves are always easier visualized in motion. So if you kind of scan up, scan down, you get a better idea of the borders of your nerve. Another cool thing, of course, is you can bend and straighten the elbow while you're scanning to see if they're having subluxing of the nerve. And then as you all know, EMGs just aren't super sensitive for cubital tunnel. So this is a great way to diagnose it in the more mild stages. So again, it's 10 or above. This one here is kind of normal. This is just showing exactly sort of how you find it. So your medial epicondyle, your olecranon, you're going to draw a line basically between them, place your probe right over it, and you should get a picture sort of like this. And then if you're injecting, your needle would go right there. You're just going to kind of infiltrate that whole area. Decker veins is another fun one to do. I use this example because this person A had a lot of sort of adipose tissue around their wrist, so it's harder to see anatomy. And then they had this huge vessel right here too that you actually couldn't see. So it was just kind of confirming it's good to use ultrasound. You're missing important structures. And you can see the fluid kind of going right in the sheath and around those tendons. You can also even see if they do have that septum, you'll be able to see that on the ultrasound. So Decker vein, super easy. Again, you're just placing the probe right over the radial side of the wrist and dropping the needle right in. UCLs. So this is a fun one, diagnostic procedure. This really exemplifies one of the beauties of ultrasound is you can look at both of their hands in one visit rather than ordering 2 MRI scans. The other thing is you're doing a dynamic procedure with the scanner on it, where an MRI is really just one still image in time. So this patient had a sprain, which is the left, and then her normal thumb on the right. And you'll see when I ulnar deviate under the ultrasound, the bones separate a ton, where on the right here, they barely separate. And then you can kind of still see that ligament right here is nicely intact, even though it is kind of stretched out. Same thing here, you can see the ligament, but they like barely move and they bounce right back together. So here we go. This is actually a patient who came in with a center lesion that we were able to diagnose with ultrasound. And I love this example because the beautiful thing is like it doesn't take much to realize that there's a huge difference in these 2 images. Like this looks nice and smooth, and this is just a ton of humble jumble, edema. Not even sure what it is, but it's clearly pathologic. It's just so different looking. So we put this up. This is kind of what we're looking at here, the UCL, the aponeurosis. All of that is it kind of tucked under the aponeurosis. So if we go back, that's what all this kind of junk is right here. So this patient came in, had this ultrasound done, and we were able to get her into surgery the next day and skip the whole MRI, wait for that, read it, see her back. So it saved her a lot of time, saved her some money as well. And then I know we don't all do shoulder injections here, but I just wanted to include them because there's a lot of cool ones you can do. And again, it was kind of confirmed that using ultrasound makes sure that these are more accurate. So you have your biceps tendon sheath on the left going right in here. The middle is your glenohumeral joint. You'll see kind of ball and socket right at the bottom, and then your AC joint. Again, it's a nice tool for the patients, and you can look at a lot of things while you're doing it. So glenohumeral joint, I mean, I point out their infraspinatus. I show them how it works. The biceps too, you can move their arm externally, rotate, and see does that bicep stay in that groove, kind of as a diagnostic tool. And then just some quick tips and tricks to using ultrasound, incorporating it into your practice. So for room setup, you want to make sure you don't have any windows because it helps with the glare on the screen. You want the patient to be between you and the scanner for the best view, and the less movement you have, the less you are to shift your hand and shift the image on the probe. You want to have lots of jelly available. You can never have too much. All your injection supplies within reach and ready. And then make sure your patient is nice and stabilized because, again, little movements really change your picture. This is the example, never too much jelly. The ultrasound gel is what conducts the waves. So you can see if this gap isn't filled in, you get all this blurry stuff. So this is kind of how you're ultrasounding bony surfaces, is filling it in with gel. Holding the probe, you want to hold it as close to the patient as possible. 3 points of contact. That's this picture down here. And then that cord can be heavy. So if you stabilize it, either wrap it around your hand or between your legs, that also helps prevent all the little movements that really change your picture. Okay, this is the boring slide, but take a screenshot. To bill for ultrasound, you do have to have all the images saved, so they need to be able to somehow go to your PACS system. There's a code for ultrasound guidance of the needle that you'll just tie to the injection code of whatever specific injection you're doing. And then the limit exam, the complete exam. So limited, you're looking at one structure. So say you're looking at just a ganglion cyst or a mass. Complete exam is you're looking at truly the joint, tendon, and ligament. And then here I just kind of have a little blurb of how I dictate when I'm looking at a carpal tunnel, just what I would say there. Wonderful. My info if you need it.
Awesome. Great talk, Sarah. That was excellent, especially in ultrasound, which is becoming much more in use nowadays. And I think this is kind of the way we're going. So awesome. If we want to have all of our speakers come up to this, have their videos on, we'll go ahead and answer some Q&A. We have a few moments to do that. So I'll begin by answering or actually mention the question that was asked of Dr. Recant. So being able to bill for a pin removal from a post-op fracture. And Mark, you want to just answer that on the webinar directly?
Absolutely. Yeah. I mean, that's really one of the other critical modifiers that I went through, and those are readily available, and you'll see this is recorded. But there's a specific modifier, 24, that is specifically geared towards procedures that are done that are related but not related during the global period. So for me, that painful hardware is a separate ICD-10, and that requires a separate surgical procedure, which is the pin removal. And then your coders would just add the 24 modifier to it.
Awesome. Thanks. I'd like to remind the audience, if you have any questions, please put them in the chat box. We can answer them in the next few moments. I have a question for you, Courtney. So when you're doing your office procedures, how's the flow when you have that who's assisting you? Do you have like an MA or an RN, or how does that work?
Yeah, great question. So in our clinic, we have one nurse that floats between all the hand surgeons and APPs. So you have to be strategic with it, but usually each provider has 3 rooms going at a time. So what I'll do is typically place the order in. I'm fortunate that the nurse will come in, help get the patient cleaned up. And then when they are ready and the patient's been consented for the injection, then I'll just hop back in, do the injection, and keep things moving. So that's how it flows for our clinic.
Awesome. Any other points from Sarah, Mark, and anything different from your clinics? Go ahead,
No, I
Mark.
wanted to make a brief comment. Sarah's talk was fantastic. And one of the things that always comes up is how do you get started? And what I point out to my fellows, residents, and again, the APPs, is the anesthesiologists are using ultrasound regularly. And it's something that you can pick up while the patient's waiting to go back. And their ultrasound machines are readily available for you to use. You may not necessarily get billing for those, but that's another way to get your hands on it and keep the patient busy and improve your learning.
Yeah, I would say I did that a lot at the beginning too, just take it into any room I could and not ever like necessarily knowing what I was looking at, but just scanning to look at things and better understand how things work and what you're seeing. So yeah, I wasn't billing for it at first, but just getting the hang of it.
No, that's great. Mark actually took my question for you, Sarah. I was going to exactly
Oh,
ask
sorry.
that question. So that's awesome. That's really funny. One thing, just to follow up on that, when you're doing ultrasound, I know there's, and this is a little bit in the nuances. Are you using your right hand for the injection and left for the ultrasound or for the probe, or vice versa, or how are you?
Yeah, it depends on the side. So
Okay.
both
Okay. So
alternating, yeah. Yeah.
excellent. And I think that's an important point because I think in ultrasound, I think more so than that than in other areas, you really have to be ambidextrous and being able to get access to do that. I don't know if you want to speak on that. Is that
That
what
is
you've normally
true.
seen, or
Yes, a mentor of mine made me brush my teeth with my left hand for a few months at the beginning. So yeah. And then a silly tip, but definitely like eat your breakfast before you come in to do injections. You don't want to be shaky.
excellent point. And Mark, for you, so what's the best way to access that work RView table? Did you create that or did you find that online, or because I know there's different, programs that are out there that give you information on CPT coding. A lot of them you have to pay for, but I don't know, is there any like easy way to access that?
Yes, some of those were made by others, and those are sort of paid sites. The best and the cheapest is to use our tax dollars, which is the CMS.gov website. You click Medicare services, and we're all using the physician fee lookup tool because that's really what APPs and physicians are looking to get reimbursed. And then you just have to agree to it. It's free, and then you put in your 5 codes, you put in your location, and it'll spit out the reimbursement. It'll spit out what you get in the office, what in the OR, what your RVUs were, and then if you scroll across to the right, you'll get those globals and the assistant yes or no. And so then you can make your own tables with that, or perhaps by next year I'll make a Excel sheet of all those codes for everyone to have. Be a little project.
That'd be great. And I think we have a couple of questions in our chat box. So one was, can you bill, I guess, for that pin removal, even if your surgeon puts it in? And I think, and I think you noted that if you assist, you can bill if it's documented. But I think the question also may be referring that if the pin is pulled out and the surgeon put it in, they can bill it also as a separate procedure in a postoperative period, right?
Yes, they may. Oh, I misread the question. So if the surgeon puts the pin in, taking the pin out is fair game for any APP, you, me, or anyone else in the US. So that's a whole separate diagnosis and a whole separate procedure.
Awesome. And then another question is, are there any courses that you recommend for the use of ultrasound with these procedures? So
Yeah, PAOS, the PA Orthopedic Society, has 2 a year. So one is just like a weekend ultrasound course, and then they actually do it at their annual meeting too, which is a great one. Um, and then sometimes the ASSH will have courses, pre or post courses with some ultrasound.
excellent. Well, I think seeing no more questions, we'll probably go ahead and conclude in a moment here. But I first want to really thank our speakers. I mean, these were all 3 fantastic talks. I mean, I'm going to watch this webinar again because this was really, really high yield. So congratulations on wonderful talks, and thank you again for giving them. And I want to thank the audience members for watching, and thank Endo for sponsoring this. And don't forget, we have another webinar coming up next month, and you can again get that QR code from our website as well. well and register, and make sure you attend 2. If you haven't attended the previous webinar, make sure you attend the second one so you can be accredited and get access to the membership registration. But thank you again, and have a good night, everyone.
Thanks for putting this together, and thanks all.
Thank you.